They told me my grandmother was just tired, that at 83, it was normal for her to sleep more, that I shouldn't worry. But when I walked into that room unannounced on a Tuesday afternoon and saw her eyes, vacant, unfocused, struggling to recognize my face, I knew something was terribly, terribly wrong. Because the woman who raised me, who never missed a Sunday service, who could recite poetry from memory and correct my grammar with a single look, was gone. And in her place was someone I barely recognized. My name is Jasmine, and I'm about to tell you the story of how I discovered that the nursing home we trusted with my grandmother's care had been systematically sedating her without our knowledge or consent. This isn't just about one facility or one family. This is about what happens when we place our faith in systems that see our elders, especially our Black elders, as problems to be managed rather than people to be honored. If you're watching this because you care about the dignity of our elderly, please subscribe to this channel. And tell us in the comments what city you're listening from. Your voice matters in this conversation. My grandmother, Dorothy Mae Johnson, wasn't just any woman. She was a force. Born in 1942 in rural Georgia, she picked cotton as a child, marched for voting rights as a young woman, and raised 4 children on a seamstress's salary after my grandfather passed. She taught me to read before I started school. She taught me about pride, about standing tall even when the world wanted you small. When I was 7 and came home crying because a teacher said I was too loud, Grandma Dorothy sat me down and said, "Baby, they've been trying to silence women like us for centuries. Don't you dare turn down your volume for anybody." That's who she was. Sharp, present, alive. So when she turned 80 and her knees started giving out, when the stairs in her house became dangerous and she had a small fall, we made the hardest decision a family can make. We started looking at nursing homes. Not because we wanted to, but because we worked full-time jobs and couldn't provide the round-the-clock care she needed. I spent 3 months researching facilities. I read reviews, visited 7 different places, asked about staff-to-patient ratios and activities programs. Meadowbrook Senior Living seemed perfect. Clean halls, smiling staff, an activities coordinator who promised personalized care plans and dignity-centered approach. The director, a white woman in her 50s with a warm handshake, assured me, "We treat every resident like family." The monthly cost was brutal, nearly $4,000, but we pooled resources. My mother, my 2 aunts, and I split it. If it meant Grandma Dorothy would be safe, comfortable, and respected, it was worth every penny. The first 2 weeks seemed fine. When I visited, Grandma was in the common room, playing cards with other residents. She complained about the food being bland, which actually made me feel better. That was the grandma I knew, never one to hold her tongue. She asked about my job, my daughter, whether I'd been to church. She was herself. But then, something shifted. The 3rd week, when I arrived for my usual Saturday visit, I found her in bed. Middle of the afternoon, curtains drawn, still in her nightgown. A nurse I didn't recognize, young, couldn't have been more than 25, was adjusting her blanket. "Oh, she's just resting," the nurse said with a quick smile. She had a big morning. I looked at my grandmother. Her eyes were closed, her breathing slow and deep. "Grandma," I said softly, touching her hand. She stirred slightly but didn't wake. "She sleeps a lot now," the nurse added, already moving toward the door. "It's normal at her age." I wanted to believe that. I needed to believe that. So I sat with her for an hour, holding her hand, telling her about my week, even though she didn't respond. When I left, I told myself it was just a tired day. Everyone has tired days. But the next Saturday, the same thing. And the Saturday after that. Each time I visited, Grandma Dorothy was asleep. Deep, heavy sleep. The kind where you can barely rouse someone. The staff always had explanations. She was up early. She had physical therapy. The medication for her knees makes her drowsy. That last one stuck with me. Medication for her knees? She'd been taking the same arthritis medication for years. It had never made her this sleepy before. I started visiting at different times. Tuesday morning at 10. Thursday afternoon at 3. Friday evening at 6. It didn't matter. Every single time, my grandmother was either asleep or so groggy she could barely keep her eyes open. When she was awake, her words were slow, slurred almost. She'd look at me with confusion, like she was trying to remember who I was. This woman who used to debate politics with my mother and quote Maya Angelou over Sunday dinner couldn't string together a coherent sentence. How long has she been like this? I asked a different nurse one day, trying to keep the panic out of my voice. The nurse, an older black woman who'd been kind during previous visits, glanced toward the hallway before answering. She sleeps most of the day, honey, she said quietly. There was something in her eyes, something that looked like pity, or maybe warning. That night I couldn't sleep. I kept seeing Grandma's face, slack and empty. I kept hearing that nurse's voice. She sleeps most of the day. Not some of the day. Most of the day. I grabbed my phone and started researching. Over-sedation in nursing homes. Elder abuse. Chemical restraints. The articles I found made my stomach turn. Stories of facilities using psychiatric medications to keep residents manageable. To keep them quiet. To reduce staffing needs. I thought about the Grandma Dorothy I knew. The woman who woke at 5:30 every morning without an alarm. Who never napped, said sleeping during the day was wasteful. And now she was sleeping 16 hours a day. Something was wrong. And I was about to find out just how wrong. The next time I visited, I didn't call ahead. I brought my phone. And I started asking questions that nobody wanted to answer. I changed my approach. No more scheduled visits. No more calling ahead to let them know I was coming. If something was happening to my grandmother, I needed to see it without giving anyone time to prepare. The following Wednesday, I left work early and arrived at Meadowbrook at 2 in the afternoon. I signed in at the front desk, smiled at the receptionist, and walked straight to Grandma's room. The door was slightly ajar. Inside, the lights were off despite the bright afternoon sun outside. The curtains were drawn tight, and there was my grandmother, lying in bed in the exact same position I'd seen her in 3 days earlier. I stood in the doorway for a moment, just watching. Her chest rose and fell with deep, rhythmic breaths. Her mouth was slightly open. One arm lay across her stomach, the other at her side. She looked peaceful, I suppose, but she also looked absent. Like her body was there, but she wasn't. "Grandma," I said, walking to her bedside. "Nothing." "Grandma Dorothy, it's Jasmine." I touched her shoulder gently, then a little more firmly. Her eyelids fluttered but didn't open. I shook her arm. "Grandma, wake up. It's me." Finally, her eyes opened halfway. They were glassy, unfocused. She looked in my direction, but not at me. She mumbled, the sound barely coherent. "Grandma, it's 2 in the afternoon. Have you been asleep all day?" She blinked slowly, like each blink took effort. Her lips moved, but no words came out. Then her eyes drifted closed again. I felt something cold settle in my chest. This wasn't normal tiredness. This wasn't even normal sleep. This was something else entirely. I found a nurse in the hallway, a different one, white, maybe in her 30s, with a badge that read Kelly. "Excuse me," I said, trying to keep my voice level. "I'm Dorothy Johnson's granddaughter." She's barely responsive. "Is she okay?" Kelly gave me a practiced smile. "Oh, Mrs. Johnson is fine. She just tires easily." "This isn't tired," I said. "She can't stay awake for more than a few seconds." "Is she on new medication?" "Let me check her chart," Kelly said, pulling out a tablet. She scrolled for a moment. "She's on her regular medications. Nothing new." "What are her regular medications?" Kelly's smile tightened slightly. "I'd need to speak with the nursing supervisor about releasing that information. Privacy regulations, you understand. I'm her granddaughter. We're paying $4,000 a month. I'm asking what medications you're giving her." "And I'll have the supervisor call you," Kelly said, her tone still pleasant but firm. "Is there anything else I can help you with today?" I wanted to scream. Instead, I smiled back. "No, thank you. I'll wait for that call." I went back to Grandma's room and sat with her for 2 hours. In that entire time, she woke up once, looked at me with those foggy eyes, whispered something I couldn't understand, and fell back asleep. I took out my phone and started taking notes. The time, her condition, the fact that her dinner tray from lunch was still sitting untouched on the table, the food congealed and cold. When I left, I stopped by the front desk. "I'd like a copy of my grandmother's medication list," I said to the receptionist. "You'll need to submit that request in writing," she replied without looking up from her computer. "In writing?" "Yes, ma'am. You can email our administrative office." The address is on our website. I drove home in silence, my hands gripping the steering wheel too tight. That night, I sent the email. I also called my mother and my aunts. Something's wrong with Grandma, I told them. Really wrong. My mother, always the optimist, always wanting to see the best in people, tried to reassure me. Baby, she's 83. Maybe this is just what happens. Mama, this is not just what happens. She can't stay awake. She can't talk. Something is wrong. My Aunt Regina, the pragmatic one, suggested we request a family meeting with the nursing home staff. We need to get everyone in a room and ask direct questions, she said. So that's what we did. I sent another email requesting a care conference. The response came 2 days later. They could meet with us in 2 weeks. 2 weeks felt like an eternity, but I agreed. In the meantime, I visited every other day, always unannounced, always taking notes. And every single time, the same thing. Grandma Dorothy asleep or barely conscious. On one visit, I arrived just as they were bringing her lunch. The aide set the tray on the table and left without waking her. I waited to see if anyone would come back. No one did. For 40 minutes, her food sat there while she slept. When I finally woke her myself and tried to help her eat, she could barely hold a spoon. Her hand trembled. She took 2 bites of mashed potatoes and fell back asleep. I started documenting everything with my phone. Photos of her sleeping at different times of day. Videos of me trying to wake her, her slurred responses. The untouched meal trays. I didn't know what I'd do with the evidence, but some instinct told me I needed it. One afternoon, I ran into that older black nurse again, the one who'd looked at me with pity weeks earlier. Her name tag read Patricia. She was coming out of another resident's room when she saw me in the hallway. "How's your grandmother doing?" she asked. "She's asleep," I said. "Like always." Patricia glanced around, then lowered her voice. "You're here a lot." "Because something's not right?" She held my gaze for a long moment. There was something she wanted to say. I could see it in her eyes, in the way her mouth opened, slightly, then closed again. Finally, she said, "Keep visiting. Keep asking questions." Then she walked away. Keep asking questions. That wasn't reassurance. That was a warning. Or maybe permission. The care conference was scheduled for a Friday at 10 a.m. My mother took off work. So did Aunt Regina. We arrived together, a united front, and were led to a small conference room with a table and 6 chairs. Already seated were the nursing director, a white woman named Susan, maybe 55, with reading glasses on a chain, and a young man introduced as Dr. Chun, our consulting physician. "Thank you for coming in," Susan said with a warm smile. "We always appreciate family involvement in our residents' care." I didn't waste time with pleasantries. "My grandmother is asleep every time I visit. She's barely responsive. She can't feed herself. What's going on?" Susan folded her hands on the table. "Mrs. Johnson has been experiencing some behavioral challenges." "Behavioral challenges?" I repeated. "What does that mean?" Dr. Chin spoke up. "Your grandmother was exhibiting some agitation in the evenings. Anxiety. Some confusion. So you sedated her?" My voice came out sharper than I intended. "We adjusted her medication to help manage her symptoms and ensure her safety," Susan said calmly. "It's quite common in patients her age." "What medication?" Dr. Chin glanced at a file in front of him. "She's on a low dose of quetiapine. It helps with sleep regulation and anxiety." I pulled out my phone and opened my notes app where I'd researched that exact drug the night before. Quetiapine is an antipsychotic. My grandmother doesn't have psychosis. She has arthritis. It's used off-label for a variety of conditions, Dr. Chin said. "It's very safe and effective." "Effective at what?" "Keeping her unconscious." Susan's smile remained fixed. "Mrs. Johnson is not unconscious. She's resting comfortably. She can't stay awake for more than 5 minutes. She doesn't recognize me half the time." "How is that comfortable?" My mother put her hand on my arm. "What Jasmine is trying to say is that this doesn't seem like our mother. She was so alert before. The adjustment period can take some time," Susan said. "But we've seen significant improvement in her evening agitation." "Because she's too drugged to be agitated," I said. The room went quiet. Dr. Chin closed his file. Susan's smile finally faded. "Miss Johnson," she said, her voice still calm but cooler now, "I understand your concern. But we are professionals. We see hundreds of elderly patients. We know what's best for their care and safety. Your grandmother was becoming a danger to herself and others. This medication is necessary. A danger how? She was wandering, attempting to leave the building, getting confrontational with staff. I stared at her. My grandmother, who could barely walk without a cane, was wandering and confrontational. I want to see the incident reports, I said. Those are internal documents. She's my grandmother. I have a right. You have a right to be informed of her care plan, which we're doing right now, Susan interrupted. But internal staff reports are confidential. What I can tell you is that the care team made the decision that this medication was in your grandmother's best interest. I looked at my mother. I looked at Aunt Regina. They both looked as frustrated and helpless as I felt. Can we try reducing the dosage? My mother asked gently. Just to see if she becomes more alert. Dr. Chun and Susan exchanged a glance. We can discuss that with the care team, Susan said. But I want to be clear that any changes to her medication regimen need to be done carefully and gradually. How gradually? We'll evaluate in 30 days. 30 days. Another month of my grandmother sleeping her life away while they evaluated. We left that meeting with nothing. No answers. No changes. Just promises to monitor the situation and keep the family informed. As we walked to the parking lot, my mother was quiet. Aunt Regina was angry. And I was something else entirely. I was certain. I went home that night and did something I probably shouldn't have done. I called a lawyer, and I started planning my next visit to Meadowbrook, one they definitely wouldn't see coming. The lawyer's name was Michelle Torres, and she specialized in elder abuse cases. When I called her office and explained the situation, her paralegal scheduled a consultation for the next day. I took a late lunch and drove to her office in downtown Atlanta, a small practice in a renovated brick building. Michelle was younger than I expected, maybe 40, with dark hair pulled back and sharp, intelligent eyes. She listened to everything without interrupting. When I finished, she leaned back in her chair. What you're describing is called chemical restraint, she said. It's when facilities use psychiatric medications not to treat a medical condition, but to control behavior, to make residents more manageable. Is that legal? It's complicated. It's legal if there's a documented medical need and informed consent. But it's abused constantly, especially in understaffed facilities. And especially, I'm just going to say it plainly, with Black and brown residents. My stomach tightened. What do I do? You need documentation, medical records, incident reports, proof that she didn't need this medication, or that the dosage is excessive, or that you weren't properly informed. Do you have power of attorney? My mother does. Then your mother needs to formally request all medical records. They have to provide them within 30 days by law. Request everything: medication logs, doctor's notes, nursing assessments, incident reports. Everything. I took notes furiously. What else? Keep visiting. Keep documenting. Times, dates, her condition. If possible, try to observe what's happening when you're not there. She paused. Do you have any allies inside the facility? I thought of Patricia, the nurse who told me to keep asking questions. Maybe. Approach carefully. Staff can face retaliation for speaking out. But sometimes, they're the only ones who know what's really happening. I left that meeting with a plan. First, my mother submitted a formal written request for all of Grandma's medical records, citing her power of attorney. Second, I started visiting at odd hours, early morning, late evening, the times when staff might be less vigilant. Third, I waited outside Meadowbrook one afternoon until Patricia finished her shift. She walked out just after 3 p.m., still in her scrubs, heading to a blue Honda in the parking lot. I intercepted her gently. Patricia, I'm Jasmine, Dorothy Johnson's granddaughter. Can I talk to you for just a minute? She looked around nervously. I can't. I don't want to get involved. I'm not asking you to accuse anyone. I just need to understand what's happening to my grandmother. Patricia's shoulders sagged. For a moment, I thought she'd walk away. Then she said, Not here. Follow me. We drove to a coffee shop 2 miles away. Inside, sitting in a corner booth away from other customers, Patricia wrapped her hands around a cup of tea and finally spoke. Your grandmother isn't the only one, she said quietly. It's not official policy, but it's understood. When residents get difficult, asking too many questions, complaining, resisting care, they get put on something to calm them down. Quetiapine, Haldol, Ativan. The doctors write the orders. The nurses give the meds. And the residents sleep. How long has this been going on? Years. But it's gotten worse. They're understaffed. Corporate keeps cutting budgets. It's easier to sedate people than to actually care for them. Was my grandmother difficult? Patricia looked at me with sad eyes. Your grandmother told a nurse she wanted to call her family to complain about the food. She said she wanted to report that someone had taken money from her purse, which, by the way, probably happened. The next day, Dr. Chin came in and wrote an order for quetiapine. Said she was showing signs of paranoia and agitation. I felt rage bloom hot in my chest. Paranoia? She was trying to protect herself. I know. I've been a nurse for 26 years. I know the difference between dementia and someone being rightfully upset. But I'm not the doctor. I don't write the orders. Do you give her the medication? Patricia looked down at her tea. Sometimes, when I'm assigned to her, I give the minimum dose I can get away with. But other nurses give the full amount, and they give it 3 times a day. 3 times a day. No wonder Grandma couldn't stay awake. Why are you telling me this? I asked. Patricia met my eyes. Because I've seen this happen too many times. And almost always to Black women. Women who built this country, who survived Jim Crow and raised families and worked their fingers to the bone, and this is how they're treated at the end? Drugged into silence. Her voice cracked. Your grandmother deserves better. They all do. I reached across the table and squeezed her hand. Thank you. I can't testify or anything official. I have 3 kids and a mortgage. I understand. But this helps. It really helps. 2 days later, armed with Patricia's information, I decided to visit Meadowbrook at 6 a.m., before the day shift fully started, when fewer administrators would be around. I signed in with the overnight receptionist, who looked half asleep, and walked quietly to Grandma's room. The door was closed. I opened it slowly. Inside, the lights were off, but the early morning sun was just beginning to filter through the edges of the curtains. Grandma was in bed, asleep as always, but something was different this time. On her bedside table, I saw a small paper cup with pills still in it. 2 pills. 1 white, 1 pale yellow. Next to it, a chart on a clipboard that had been left behind, probably by the night nurse during final rounds. I looked at the pills. Then I looked at the chart. My heart pounded as I picked it up and started reading. It was a medication administration record. Columns and rows listing medications, dosages, times, and nurse initials. I found my grandmother's section. And there it was in black and white. Quetiapine 100 milligrams. 8 a.m., 2 p.m., 8 p.m. 100 milligrams, 3 times a day. I pulled out my phone and searched for standard dosing. For elderly patients with actual psychosis, the recommended starting dose was 25 milligrams with gradual increases. For off-label use in anxiety, even less. They were giving her quadruple the recommended dose for someone her age. And below that, another medication I hadn't known about. Lorazepam 1 milligram, as needed for agitation. Lorazepam. Ativan. Another sedative. As needed could mean anything. Could mean every day. Multiple times a day. I took photos of the chart with my phone. Every page. Every medication. Every dosage. Then I carefully put it back exactly where I found it. I sat down next to Grandma's bed and took her hand. Her skin was cool and dry. Her breathing was deep and even. I leaned close and whispered, Grandma, I'm going to fix this. I promise you. I'm going to fix this. She didn't respond. Didn't move. But I made that promise anyway. When I left Meadowbrook that morning, I drove straight to Michelle Torres's office and sent her the photos. She called me an hour later. This is it, she said. This is exactly what we needed. This dosage is excessive and dangerous for someone her age. Combined with the lorazepam, they're essentially keeping her in a medically induced stupor. What do we do now? Now we confront them. Officially, we send a formal letter demanding immediate reduction of her medication, and we request an independent medical evaluation. If they refuse, we file a complaint with the state health department and consider legal action. How long will that take? The letter can go out today. Their response is required within 72 hours. And if they retaliate against her, then we document that too. And it strengthens our case. I closed my eyes and took a deep breath. This was real now. We were really doing this. That afternoon, Michelle sent a formal letter to Meadowbrook Senior Living on her law firm's letterhead. It outlined our concerns, cited the excessive medication dosages, referenced federal regulations on informed consent and chemical restraints, and demanded an immediate care plan meeting with full medication review. The response came faster than I expected. Not 72 hours, 24 hours. A phone call from Susan, the nursing director. Her voice was tight, controlled. Miss Johnson, we received the letter from your attorney. I want to assure you that we take these concerns very seriously. Good. Then you'll reduce her medication immediately. We'd like to schedule a meeting with you, your family, Dr. Chen, and our corporate compliance officer to discuss the situation. When? Tomorrow at 2 p.m. I almost laughed. 2 weeks for a regular care meeting. 24 hours when a lawyer got involved. We'll be there, I said. I walked into that meeting the next day with my mother, my aunt, my attorney, and a folder full of photographs. And I watched their faces change when they realized we knew everything. The conference room was more crowded this time. Susan, the nursing director, sat at the head of the table with Dr. Chin to her right. Across from them was a man in a gray suit who introduced himself as Marcus Davenport, corporate compliance officer for the company that owned Meadowbrook. His handshake was firm, his smile professional and empty. My mother, Aunt Regina, Michelle Torres, and I sat on the opposite side. I placed my folder on the table in front of me, but didn't open it yet. Marcus opened with practiced sympathy. First, let me say that we appreciate you bringing your concerns to our attention. The well-being of our residents is our top priority, and we want to address any issues you've identified. Michelle didn't wait for me to respond. My client has documented evidence that Mrs. Dorothy Johnson has been administered excessive doses of psychotropic medication without proper informed consent and without medical necessity. We're here to discuss immediate corrective action. Susan's expression tightened slightly. Mrs. Johnson was prescribed medication by a licensed physician based on documented behavioral concerns. Everything was done according to protocol. What behavioral concerns specifically? Michelle asked. Dr. Chin pulled out his own folder and flipped through pages. Mrs. Johnson exhibited agitation, confusion, wandering behavior, and verbal aggression towards staff on multiple occasions in early September. Show me the incident reports, I said. There was a pause. Marcus looked at Susan. Susan looked at Dr. Chen. Those are internal documents, Susan said. Michelle leaned forward. My client's mother has power of attorney. Under HIPAA and state regulations, you're required to provide copies of all medical records and incident reports upon request. We submitted that request in writing 10 days ago. Where are the documents? Another pause. Marcus cleared his throat. We're still compiling the complete file. It should be ready within the week. That's interesting, Michelle said, because we already have copies of Mrs. Johnson's medication administration records. She nodded at me. I opened my folder and pulled out the photos I'd taken, printed on regular paper but clear as day. I slid them across the table. Quetiapine 100 milligrams, 3 times daily. Lorazepam as needed, for an 83-year-old woman with no history of psychosis or violent behavior. Dr. Chin picked up the pages, his face carefully neutral. This is within acceptable dosing parameters. For what condition? Michelle asked. What psychiatric diagnosis justified this medication regimen? Dr. Chin flipped through his notes. Generalized anxiety disorder with behavioral disturbance. And who diagnosed that? I did, based on nursing observations and clinical presentation. How long did you spend with Mrs. Johnson before making that diagnosis? Dr. Chen's jaw tightened. I conducted a thorough evaluation. How long, doctor? Approximately 15 minutes. My mother made a sound, something between a gasp and a sob. 15 minutes. He decided to drug my grandmother into oblivion based on 15 minutes. Michelle pressed on. And did you obtain informed consent from the family before starting this medication? The family was informed of the care plan, Susan interjected. We were told she was on medication for sleep and anxiety. I said, my voice shaking with controlled anger. We weren't told she'd be unconscious 16 hours a day. We weren't told you were giving her antipsychotics. We weren't told about the low razepam at all. The consent was implied through the admissions agreement, Marcus said smoothly. All families sign consent for necessary medical treatment upon admission. Michelle smiled, but it wasn't friendly. Implied consent doesn't cover off-label use of powerful psychotropic medications without documented medical necessity. You know that, Mr. Davenport. I'm sure your legal team has explained it to you. The room went very quiet. Marcus adjusted his tie. Susan stared at the table. Dr. Chin closed his folder. What do you want? Marcus finally asked. Immediate reduction of Mrs. Johnson's medication under proper medical supervision, Michelle said. Independent psychiatric evaluation by a physician not affiliated with this facility. Full copies of all medical records, nursing notes, and incident reports within 48 hours. And a formal apology. Marcus looked at Susan and Dr. Chun. Some wordless communication passed between them. We can agree to a medication review, Marcus said carefully. Dr. Chun can begin tapering the dosage starting tomorrow. Not Dr. Chun, Michelle said. An independent physician. That's not standard protocol. Then change your protocol. Or we file a formal complaint with the State Department of Health and Human Services, the Office of the Long-Term Care Ombudsman, and the Joint Commission. We'll also be contacting local media about the use of chemical restraints in your facility. I watched the color drain from Marcus's face. Susan's hands clenched into fists on the table. Dr. Chin looked like he wanted to disappear. We'll arrange for an independent evaluation, Marcus said quietly. Within the week. Within 48 hours, Michelle countered. Fine. 48 hours. And the medication reduction starts today. Not tomorrow. Today. Another long pause. Finally, Dr. Chin nodded. I'll write the order this afternoon. I should have felt victorious. I should have felt relief. Instead, I felt sick. Because I kept thinking about what Patricia had said. Your grandmother isn't the only one. How many other residents are on similar medications? I asked. Everyone looked at me. Marcus's expression hardened. I'm not at liberty to discuss other residents' care. I'm not asking for names. I'm asking if this is a pattern. How many elderly people in this facility are being chemically restrained? That's an offensive characterization, Susan said sharply. We provide compassionate care. You drugged my grandmother because she complained about the food, I said, my voice rising. You call that compassionate? Your grandmother was exhibiting dangerous behavior. She's 83 years old with arthritis. What danger? What possible danger could she pose that required you to sedate her unconscious? Susan's face flushed red. For the first time, her professional mask slipped. You have no idea what it's like trying to manage residents who are constantly demanding, who don't follow instructions, who make the staff's job impossible. She stopped abruptly, realizing what she'd said. Marcus put a hand on her arm, but it was too late. There it is, I said quietly. This isn't about my grandmother's safety. It's about making your job easier. The silence that followed was heavy and damning. Michelle gathered her papers. We'll expect the independent evaluation arranged by tomorrow morning. Medication reduction begins today, and full medical records by Friday at 5 p.m. If any of these conditions aren't met, we proceed with formal complaints and legal action. Are we clear? Marcus nodded stiffly. Crystal clear. We stood to leave. As I picked up my folder, I looked directly at Dr. Chun. How many? I asked again. How many people have you done this to? He didn't answer. He couldn't even meet my eyes. As we walked out of Meadowbrook, my mother started crying. Aunt Regina put her arm around her. Michelle touched my shoulder. You did good in there, she said. Really good. But I didn't feel good. I felt hollow and furious and heartbroken. Because even if we saved my grandmother, and that was still an if, how many others were still in there, trapped in their own bodies, silenced by pills they didn't need? That night I couldn't sleep. I lay in bed staring at the ceiling, thinking about institutional power and who gets believed and who gets drugged into silence. I thought about my grandmother marching for voting rights, raising her voice when others said to be quiet, teaching me never to back down. And I realized this fight wasn't over. It was just beginning. 3 days later, I got a phone call that changed everything. The independent doctor had completed his evaluation. And what he found was worse than any of us imagined. She has mild cognitive impairment consistent with her age, and some arthritis-related pain. That's it. The symptoms that Dr. Chin documented, the agitation, the confusion, those were almost certainly side effects of the medication itself, not underlying conditions. I closed my eyes. You're saying the drugs made her worse. I'm saying the drugs created the very symptoms they were supposedly treating. It's called a paradoxical effect, and it's terrifyingly common in elderly patients. They get agitated because they're over-medicated, so the staff increases the medication, which makes them more agitated, and the cycle continues. How long will it take to get her back to normal? He was quiet for a moment. Miss Johnson, I need to be honest with you. Your grandmother has been on high doses of these medications for over 2 months. We can taper her off safely, but the cognitive effects, there may be lasting damage. We won't know the full extent until she's been medication-free for several weeks. The floor seemed to tilt beneath me. Lasting damage? Possibly. These drugs affect memory, motor function, and cognitive processing. In some cases, patients recover fully. In others, especially in the very elderly, the effects can be permanent. I sat down hard on my couch. So even if we win, we might have already lost her. I'm sorry. I truly am. But the sooner we begin the taper, the better her chances. Dr. Harrison sent his full report to Meadowbrook that afternoon. It was damning. 8 pages of medical evidence that my grandmother had been inappropriately medicated, that informed consent had not been properly obtained, and that the facility's protocols for psychiatric medication in elderly patients were grossly inadequate and potentially negligent. Michelle filed formal complaints with the State Health Department and the Long-Term Care Ombudsman the same day. Within a week, Meadowbrook was notified of an upcoming inspection. Within 2 weeks, local news picked up the story, not naming my grandmother specifically, but reporting on allegations of inappropriate sedation practices at a local nursing home. And within 3 weeks, my grandmother started to wake up. The change was gradual. The first few days after they reduced her medication, she was still groggy, still confused. But then, one afternoon when I visited, she was sitting up in a chair by the window. Actually sitting up. Actually awake. "Grandma," I said, afraid to hope. She turned her head and looked at me. Really looked at me. Her eyes were clearer than they'd been in months. "Jasmine," she said. Her voice was weak and rough from disuse, but it was her voice. "Baby, where have you been?" I started crying. I couldn't help it. I knelt beside her chair and took her hands. "I've been right here, Grandma. I've been here the whole time." She frowned, confused. I was dreaming. For so long I was dreaming. Couldn't wake up. Her hands trembled in mine. What happened to me? How do you explain to someone that they were stolen from themselves? That the place meant to care for them decided they were too inconvenient to actually care for? I tried to find words gentle enough, true enough. "You were sick, Grandma, but you're getting better now." Over the following weeks, more of her came back. Not all of her. Dr. Harrison had been right about that. Her memory had gaps. Her words sometimes came slower than before. She tired more easily, but she could hold a conversation. She could feed herself. She could smile and mean it. We moved her out of Meadowbrook within a month. Found a smaller facility with better staff ratios and transparent practices. It cost more, but we found the money. We had to. The state investigation found multiple violations at Meadowbrook, not just with my grandmother's care, but facility-wide patterns of inadequate documentation, improper medication management, and insufficient oversight. They were fined $50,000 and put on a corrective action plan. It wasn't enough, but it was something. We never pursued a lawsuit. My mother didn't want to put Grandma through it, and honestly, neither did I. We'd gotten her back, as much of her as we could. That felt like enough. But the story didn't end there. 2 months after we moved Grandma to her new facility, I got a message through the blog I'd started documenting our experience. It was from a woman named Tanya, whose mother was still at Meadowbrook. "I read your story," she wrote. "I think this is happening to my mom, too. Can you help me?" I helped her, told her how to document, who to call, what questions to ask. Her mother got off the medications, too. And then there was another family. And another. A network of daughters and granddaughters and nieces, all realizing that the exhaustion they'd been told was normal aging was actually chemical restraint. My grandmother lived another 3 years. Not as many as we'd hoped, but 3 good years. Years where she knew us, laughed with us, told stories about marching in Selma and teaching herself to sew. Years where she was herself. She passed peacefully in her sleep on a Sunday morning, with my mother holding one hand and me holding the other. Her last words, spoken the night before, were to me, "You didn't give up on me, baby. Thank you for not giving up." I think about her every day. I think about the months we lost, the fog they put her in, the voice they tried to silence. I think about how close we came to losing her completely, not to age or illness, but to a system that saw her as a problem to be managed rather than a person to be honored. And I think about all the others, the ones who don't have family members who visit unannounced, who ask difficult questions, who refuse to accept it's normal at her age as an explanation. The ones still sleeping their lives away in rooms with drawn curtains, chemically restrained because they dared to complain or question or simply exist in a way that made someone's job harder. This isn't just about one nursing home or one elderly woman. This is about how we treat the people who built the world we inherited. This is about dignity and voice and the right to be seen as human even when you're old and vulnerable and at the mercy of others' care. My grandmother used to say, "Baby, they've been trying to silence women like us for centuries." She was right. They tried to silence her at 83, just like they tried when she was 23 and marching for the right to vote. But she fought then, and I fought for her now. And if this story sounds familiar to you, if you've watched someone you love disappear into a fog that doesn't quite make sense, if you've been told it's normal when your gut says it's not, please ask questions. Demand answers. Show up unannounced. Trust your instincts. Because our elders deserve to finish their lives awake. They deserve to be heard. They deserve to be themselves until the very end. Subscribe to this channel if you believe that every elder deserves dignity and respect. And comment below where you're watching from. If you believe enough is enough, write enough is enough in the comments. Let's make sure what happened to my grandmother never happens to anyone else. My grandmother taught me to stand tall even when the world wants you small. To use my voice even when they try to silence it. And to never, ever stop fighting for what's right. I'm still fighting. For her. For all of them. And I won't stop. Dr. Robert Harrison was a geriatric psychiatrist with 30 years of experience and credentials that filled half a page. Michelle had recommended him specifically because he testified in elder abuse cases before and had a reputation for thorough, unbiased evaluations. He spent 2 hours with my grandmother. Not 15 minutes. 2 hours. He reviewed her complete medical history, interviewed staff members, and conducted cognitive assessments. When he called me with his findings, his voice was grave. "Miss Johnson, your grandmother has no psychiatric condition that warrants antipsychotic medication," he said.